Hi guys, my name is Erin. I'm one of the PM&R physicians at Emory, and I work full-time down at Grady doing consults, a lot of which start in the ICU. So I'm very thankful for everyone in attendance. The work you guys do is very important to kind of our specialty. You guys are the ones that kind of save their lives and give us a chance to work with them down the road. So thank you, and thank you for having me. No conflicts to report. I'm hoping by the end of this talk that you guys kind of understand a little bit more about what our specialty does, why we can have a role in the ICU and helping you guys out with the care of some of these complex patients, and then just going through some specific examples of situations that come up commonly in ICU and how we can help navigate those. So most specialties, it's pretty easy to kind of figure out what they do. The cardiologist owns the heart, the neurologist owns the brain. Physical medicine and rehab is a little bit tougher to kind of understand just by our name alone. We don't really have one system that we own. I think what we do own is more of a perspective of the patient and understanding kind of everything that goes in to these patients getting better from critical illnesses, injuries, and disabilities. It's kind of a favorite question to ask at kind of residency interviews, describe PM&R, and usually you get a different answer every time. But there is some typical buzzwords that come up with our specialty and kind of what we do and how to describe our approach. One of them being patient-centered. Definitely we'd like to think that we take a kind of a whole view of the patient, really looking into everything that's going into their care and kind of affecting their progress in their recovery. Right. Interdisciplinary care, that's the whole point of acute rehab, right, is to work as a team with nutrition, therapy, social work as a team to really get the patient to recover and get them out of the hospital back into the community. And this is also, the case in other levels of care too in the ICU. Being a leader of that team, so kind of being the person that goes to all the different disciplines and trying to work together to get this patient going in the right direction. Definitely function is a big word that comes up, right? Kind of maximizing their ability and therefore their quality of life. And then treating disability. A lot of people that have impairments that come to us, things they're trying to overcome or learning how to live their life in a new way. And then restoring independence. That's the whole key of rehab, is trying to get people back to doing as much as they can on their own so we can get them back into the community. One of our national organizations, this is kind of the paragraph that they use to try to explain what we do. But again, some of these buzzwords are coming up. We treat a wide variety of conditions, a lot of critical illness, disability, patient-centered approach, maximizing function and quality of life. So it really is just kind of a perspective of all the patients, not necessarily one system or one disorder. There was recently an article in JAMA that was talking about kind of an experience that a physician had with his brother undergoing critical illness just this month, actually, and I thought it brought up a couple of good points that kind of explained kind of our role kind of throughout the continuum of care, and just what he kind of noticed as his brother went through this critical illness and kind of through the different levels of care, that there wasn't always someone that was focused on his recovery and getting better and kind of addressing the benefits and risks of doing certain things, and coordinating care with all the different members of the team. He kind of came to this realization that no one's ultimately responsible to make sure that he recovers and gets back to where he was, and that could be something that's more useful throughout the continuum. And it's actually something that I think our specialty is trying to push forward a little bit, is being more present throughout the continuum of care, starting in the acute care hospitals and the ICUs, and continuing into the different post-acute care facilities. Obviously, we're known for acute rehab, being the primary physician in those centers, but also in LTACs and subacute rehab. I think our healthcare landscape is kind of changing a little bit. 20 years ago, the people that were in acute rehab, now they're going straight home from the hospital, or they're getting pushed to subacute rehab. And the people that are actually getting to acute rehab are more and more critical and have more and more complex diagnoses. than the bread and butter stuff we used to do. And then we have a big role in outpatient, kind of explodes into a bunch of different areas, which I won't get too much into today, but definitely a wide scope and a specialty that can be present throughout all levels of care. So why do we need PM&R in the ICU? So hopefully I can convince you guys that we can be helpful for a few things. Probably what you're hoping for when you consult PM&R is that the patient moves more. We know all about the complications of immobility and how important it is to get our patients moving, and there's been a lot of push for early mobility. Unfortunately, I'm not the one that's going to move them. I count on my therapist and the rest of the team to kind of help with that. But I do have an approach where I'm thinking about, okay, what is preventing the nurse from being comfortable from moving this patient, or how do we get to the point where therapy can be involved? So I am constantly looking at kind of barriers to getting that mobility going. What are some other things? I think specific diagnosis management. Like I said, we don't have a system, but I think we do own a few different diagnoses. Some of our bread and butter stuff is TBIs, spinal cord injury, strokes. A lot of those start in the ICU. It may have, complicated prolonged courses where we're trying to get rehab going, but they still have reasons that they need to be in that level of care. Preservation of function. I think it's important to have someone that's looking at the patient and thinking weeks to months down the line, what do we need to do now to preserve the function that they have, weeks down the line, preserving range of motion, for trying to prevent debility and pressure ulcers, all these things that are going to make their course much more complicated and prolonged, and making sure, once we've saved their life and stabilized them, that they're still function there to resume. Again, the patient-centered perspective, I think this is really important in the ICU when the patient often can't communicate very well, they're on the vent, they're confused, trying to figure out what things are impacting them. Are they anxious? Are they painful? Have they not slept? A lot of different things that can definitely have an impact on their recovery and how they're presenting to us every day that maybe don't get thought about by some other services. Interdisciplinary care, ICU is another area where we're focusing, or having a lot of people focusing on specific things and really trying to work and coordinate with all those different specialists to try to all focus on the patient and get them progressed and hopefully out of the ICU. Functional prognosis, I think we deal with this a lot at Grady, not only for patients, say spinal cord that's coming in, they're in the ICU, explaining to them what their recovery looks like, what we can hope for, but also talking with the families so they can kind of understand, what can I hope for after this injury? I'm making decisions on all these, invasive procedures. Like, what can I hope them to get back to? And just kind of giving them a better idea of where their functional prognosis is. And discharge planning. I think this one is huge, and I'll hopefully highlight that a little bit later. Just having someone that's thinking about how do we get them out of the hospital and back into the community from day one. I know sometimes it might seem silly, I'm walking into the room and asking the family, okay, how many steps do you have to get to your house? And they're worried about just kind of getting the patient stabilized, but thinking about those things early can help improve the ability to discharge them or get them to rehab later. So let me just go through just kind of a few examples, common things I'm helping to manage at the ICU level throughout the acute care setting. Agitation is a big one, especially with brain injury. This is a big barrier to being able to get them off the vent, get them out of the ICU, allowing them to work with therapy. And often it's very complex to know, why is this patient agitated? Is it just their brain injury? Is there something else that's kind of playing into it? So I'm constantly, talking with nurses, family, trying to figure out, are they anxious? Are they painful? What are some things that we can do to treat those things that are playing into the agitation to hopefully get it better? So if we can fix the trigger for the agitation, much likely to be more successful in getting them to a calmer state so we can progress them. And then brain injury, thinking about what medications are less likely to have harmful effects on their recovery. They're agitated, but they're still recovering from their injury. How do we avoid, slamming them with a bunch of benzodiazepine or Haldol and stuff like that. Neurogenic bladder, sometimes spinal cords have prolonged kind of ICU course, and we start to think about these things while they're still there. But really trying to think, okay, if I get this patient better and out of the hospital, do they have the functional ability to manipulate a catheter if we take the Foley out? Do they have the resources to pay for catheter supplies? We've definitely had patients that come back as outpatient and they're like, I just can't afford them anymore. I don't have my Medicaid yet, and what do we do? So just trying to think about that decision early on, and so they're successful when they do get out in the community. Spasticity is a common one, kind of on the neuro ICU side of things. Starts very early, and a lot of our medications that we have to treat it can be sedating. We're still in this kind of phase where we're watching their neurological status very closely. We don't want to necessarily throw a bunch of medications at them that might alter that status more. So what are some ways to manage it? Is the spasticity causing a problem, or is it being helpful? Are they having extensor tone in their leg that maybe is actually helping them stand and transfer? So really, that's really a team approach to trying to figure out, which things are causing a problem, which aren't. How do we handle it? And I also find that getting family involved, this is a great way. Teaching them how to do a stretching and range of motion program while they're in the ICU. They're less afraid to touch and engage with their family members, and they do a very good job with it. And it gets done multiple times a day, and sometimes can even avoid needing to start medications. So my chief told me I should probably tell you a story, so if you know who he is, it's no surprise. But I'll just tell you a case that we had at Grady recently and kind of how my involvement helped to progress the patient quicker. Okay, the case involves a young man that was involved in a motor vehicle crash. He was in a car with his brother being the driver and his father. He was ejected from the vehicle and sustained a C5 spinal cord injury, complete injury. This was a young man that kind of lit up the room. Even though he was going through this awful thing, he had an amazing smile, was definitely motivated, wanted to get better, because it was like the therapist's favorite patient. So you look at him and he's like, yes, he's a slam dunk candidate for acute rehab, right? Great premorbid function, has a terrible injury, is going to have long-term disability, needs acute rehab if he's going to get back out in the community. All right, but there's more that goes into it. Unfortunately, there's going to be several barriers to rehab placement despite just needing it. Okay, so I sat down with his family very early in the mission, along with the therapist and the social worker, to kind of talk them through what would need to happen if he was going to get to acute rehab and eventually home with them. All right, one big thing is family support. Okay, he had a girlfriend of a few months. He had an aunt that had a full-time job, and he had a brother who was struggling with his whole family being injured, and also having young kids. And you could tell he was really struggling to hang on there as well. So he had only really 3 adults that were involved in his care and were going to be able to help him. And that was key, right? Because he has an injury that we know is going to require 24/7 assistance, and only having 3 people that are in his corner at the time. His family support was there, but it was barely hanging on. Okay. Discharge environment. He couldn't go back to the place that he was living before. It wasn't accessible. Okay. Family members had another house in another county, but because of some probation issues, he couldn't go back there either. If you're going to get to acute rehab, you have to know where you're going to go after, right? So that piece was also missing, and of course he was unfunded as well. So needs rehab, but barely has the family support, no place to go, and unfunded. Because we started addressing these things a week into admission, the aunt was able to find somewhere for him to go. They were able to figure out a schedule of how they were going to take care of him after rehab. And when a charity bed came available at one of our local rehab centers, he was a great candidate, and he was able to go. And if you guys feel that at all, you know they're not always open all the time. So having him ready to go when it was open allowed him to get to that kind of next step of rehab, which he might have otherwise gotten passed by on. Okay. So I love what I do. I'm hopefully helpful to those of you at Grady, and I hope our specialty can continue to kind of progress and be available in more settings as we kind of our healthcare landscape kind of changes with more critical patients and other areas as well. So I'm happy to answer any questions you guys have on my specialty. Hopefully you understand a little bit more of what we do. I know it's kind of confusing, but happy to answer any questions.